I give it in the ASCRS and American Academy in like 90 minutes. So I'll try to throw some spotlights on this tough topic. And of course, you had the chance of dealing with Professor Muhammad Amar. I had the honor of being a colleague to my past Ahmad Amara, and he was kind of like an angel. Rahmatullah alayhim wa al-Aqeen. So the surgical principles of iris construction, it should be a closed system with a small incision surgery. And we should mobilize and free all the parts of the iris, whether the peripheral anterior synechiae or posterior synechiae. And then we are going to discuss the intraocular sutures and knot tying for the pupil repair. We have to talk about the retroflexion and antiflexion in iridodialysis. And we are going to talk about the ciliary border attachment, and definitely iris repair is better than iris prosthesis. We're going to skip the iris prosthesis for the sake of time. So the reconstruction techniques for the iris defects: modified Sipser sliding, single fourth row, hang back. Let's skip this slide because it's an enumeration of what we're going to talk about. This is the checklist of the instruments which should be in my back armamentarium: the needle 10-0 Purine suture, micro-gasping forceps, flat blunt-tipped spatulas, micro scissors, Sinskey hooks, anterior chamber maintainers, viscoelastics, 25 gauge needles, retractors, angle trying forceps, endodiathermy. And the types of the iris repair, either there is freeing of the total posterior synechiae or ring synechiae, pupillary border sutures, pupillary cerclage with iris atrophy or without iris atrophy, then iridodialysis repair. Sometimes it's combined, the iridodialysis repair with traumatic mydriasis. And we're going to talk about the change of the pupil location either by endodiathermy or excessive suturing and cutter fashioning. And then we'll talk about the pupilloplasty, pinpoint pupilloplasty. This is kind of like a very tough surgery because there is a total posterior synechiae, which is from the pupillary border to the ciliary border. There is adherence between the iris and the back of the remnants of the capsule. So you have to dissect all the ciliary sulcus all around. So sometimes when you do this section, you're doing it with some residual iris adherent to the capsule itself. Sometimes we need to free the synechiae, and for eye syndrome is not like a typical case for cataract surgeon, because you might see here that I will induce the descent membrane detachment, as you see here. Can you see that? So for a regular cataract surgeon who's not accustomed and used or trained for the DMEC surgery, it's very tough. So don't go except if you have a DMEC tissue with you, because you have to remove that descent tissue from over the surface of the iris. In some aggressive cases of eye syndrome, it's kind of like there is iridoschisis. So you need to trim the remnants of the DMEC tissue or the descent tissue by scissoring and cutting from over the surface of the iris. Otherwise, you're going to induce some sort of difficulty while you're unfolding your DMEC tissue. So these are tough cases where you have a situation with iris surgery. Sometimes we need to peel the persistent pupillary membrane from over a capsule, which is crystal clear. So you need to know how to dissect that with the viscoadaptive material like helium 5, and you do it under the surface of the iris so that you pop it like a popcorn. So it will detach from the clear anterior capsule, and at the end of the surgery you will find that the pupil is completely, there is a red reflex, and the patient regains autoref readings and a good vision. Meanwhile, because it's a pediatric age grouping, you preserve his accommodation. Now we're going to the basic suturing techniques. Since McCannell introduced his suture, there was no improvement or progress or even popularity of the iris surgery. Why? Because there was no side ports, there was no keratomes, there was no MVR. It was a big wound, and in this big wound, if you're passing the suture from this side of the iris to this side of the iris, when you try to tighten the knot, you will going to exteriorize the iris outside the anterior chamber, which is very difficult because you don't know the size of the pupil. So came later on Ike Ahmed, and he did modification of mechanical suture, but let's see, in this suture it was only one wound, but big wound. Then came Ogawa, and he thought about, instead of exteriorizing the iris tissue outside the eye, I'm going to interiorize the knot inside the eye. If you notice, both McCannell and Ogawa, it's one wound, but one of them is exteriorizing the iris outside from the one wound, and one of them is interiorizing the knot inside the eye, and it's only one wound. Each time you stop at the wound and then you push or interiorize the knot inside. So in surgery, I'm going to exteriorize both ends of the suture, take my throwing, and then with the aid of the Sinskey hook, I'm going to push the Sinskey hook. The knot will go into the pupillary border as shown here. Then came Sipser. When I talked to Sipser why there was no popularity of the iris surgery, because there was no keratomes or MVRs till the late 90s. For Sipser, he started to think about two wounds 180 degrees opposite each other, and then when you have your throws, then there is a loop, and then you're going to interiorize or slide the loop inside the eye. But for this knot, there should be two wounds opposite each other, 180 degrees opposite each other. Then came Agrawal group, and they thought about a single 4-throw pupilloplasty, which is something that it kind of like saves time, because you don't have to get many loops, like 3 loops, 2, 3, 3, 3, 2, 1. So you're going to have 4 throws and then 1 knot. But if you think about it, this is not a true knot because it's a helical thing. Why it's a helical thing? This is schematic with the courtesy of Agrawal. It shows that we are going to have 3 or 4 throws over each other. It can work provided there is a support behind the iris. If the iris is having an aphakia and you're having a deepened anterior chamber, this is a helical, so the iris will go backward and it will be structured so the knot will be disengaged from each other. So as you see, it's a helical knot. It's not a true knot. So if there is no support behind the iris will be stretched backward and it will be disengaged. Sometimes we need, as corneal surgeons, some sort of compartmentalization of the anterior chamber in endothelial keratoplasty, like big iridectomies like this, but we know the principle of the Sipser knot, which is the most famous one right now, before introducing your endothelial tissue. Again, big iridectomy. For the sake of time, I'm going to skip it. Again, big iridectomy. I'm going to do the Sipser knot, sterilize the loop, and then take it outside. Sometimes we have a big iris cyst, which is due to a neglected rupture globe with bad rupture globe. So this means that we have an iris cyst which is recurrent whenever you remove it. So you either remove it with surgical excision, even with a part of the normal iris, and then you start doing your sutures after implanting your intraocular lens, preparing for the next coming endothelial keratoplasty in another session. Sometimes we have an iris coloboma, and in such a way we have to have like a rotational flap of the iris tissue. So I'm going to cut the iris here and then move it to this area and then take the sutures here, and then you can do the iridodialysis repair as if simulating the iridodialysis in such a case. Now we're going to talk about iris cerclage. So for the iris cerclage, we will have at least between 3 and 4 openings, 4 cardinal openings at the 4 quadrants, and then we're going to have introduction of the needle. We'll take 4 bites in each, 4 to 6 bites in each quadrant, externalize the needle here, and then we are going to go inside again, do 4, 6 bites here, and then exteriorize again, and then do the same procedure. For the remaining quadrant, you can see that we have 3 quadrants here. The direction of the needle is anti-clockwise. Meanwhile, the remaining quadrant will be clockwise. So that if I'm going from this wound, I will be exteriorizing the both haptics or both ends of the thread from the adjacent wound, like what will be shown here. So here is a case where we have double impact. There is subluxation, dense cataract, and traumatic mydriasis. So I'm removing the cataract, fixing the bag, putting the eye segment, and fixing my bag with the scleral fixation. And then after that, I don't do except pre-place suture. You don't have to tighten your suture like the final knot. And then you're going to do stretchability of the iris and take baseball sutures, and then you exteriorize your needle from here. In order not to catch any corneal tissue, you have to feed it inside the cannula. So the cannula will be the guidance of exteriorizing the needle. And then we're going to take the second quadrant and the third quadrant. All of the 3 beginning quadrants, they are anti-clockwise. Because the needle there is 2 needles and with 1 thread. So for the remaining quadrant, because if you're right-handed surgeon, this means that you're going with the remaining quadrant anti-clockwise, as you see here. So I entered from this wound, but I'm going to exteriorize both ends and both needles from this wound. I hope that I make myself clear. And then once you have both wounds, both ends of the needle outside the wound, then if you leave both ends outside and then try to lighten, this means mechanical. If you're going to interiorize the knot inside, this means ogwa. If you're going to introduce one of both ends from the other wound, it will be sepser, or inside the anterior chamber, it will be eye. 4 maneuvers: mechanical, ogwa, sepser, eye. Pupillary cerclage with iris atrophy. The problem is with iris atrophy, you will have some sort of very atrophic iris and is not stretchable, which means that you might induce some sort of iridodialysis. You're going to do some sort of avulsion of the ciliary border from its attachment to the sclera. So we're removing the cataract, implanting the lens. For the sake of time, I want to watch here. Once I start to pull the iris in this atrophic area, you will have the bleeding. Once you have the bleeding, you will need 2 maneuvers. The viscoelastic to pressurize the eye, but this is not enough. The presence of an air bubble together with the viscoelastic induces some sort of drying. So you inject the air nearby the bubble, nearby the bleeding, and then you inject the viscoelastic. So the viscoelastic pressurizing and the air bubble dries together with compression of this bleeding area. Then you start do the same maneuver. You have to check your needle before you start. Sometimes it's double needles, sometimes one of them is straight and the other is curved. So if you is put in such a situation, then you have to change your location. Once you finish, as you see here, I'm going to change. Now the scleral flap is in the upper, in the left side, because I changed my situation, okay? So for such a case, always remember that I'm going to do a peripheral iridectomy. So if you're going to exteriorize the iris tissue with a forceps to do the iridectomy with a scissor, this means that you're going to do a cheese wiring of the pupilloplasty, which you did. So in such a case, elevate the flap, do the peripheral iridectomy with the cutter. this is what I was saying right now, in order to avoid the cheese wiring. So sometimes if the bites of the pupilloplasty or the cerclage, they are wide, you will find these areas, okay? And these areas, sometimes they are very troublesome to the patient because the patient sees ghost of images. It's kind of like correctopia. So you corrected the midriasis, but you initiated correctopia. So you have to close all these defects. And before trying to close your pupilloplasty, if you find something like this, you take interrupted suture in this area, and then with the Simpson knot, then you close this defect. For the open sky cerclage, it's the same. What if a retropupillary maneuver after cerclage is needed? For examining the periphery of the retina, then now there is the optus, which you can see the periphery of the retina through a 2 or 3 millimeters diameter of the pupil. But if there is a retropupillary maneuver of the cerclage and you think that the 10-0 Prolene suture is very thin, it's very difficult, it's very tough. If you're going to exchange the lens, you have to cut the suture. Otherwise, if you're trying to push the lens through the pupil, through these sutures, nothing will happen except cheese wiring and more trauma to the iris. Then, once you do a retropupillary maneuver, cut the suture, inject viscoelastic, the pupil is flayed, so it will open. Once you do that, you repeat your cerclage. Avoid pulling the lens from the posterior surface or the posterior segment into the anterior segment. You will induce more trauma to the iris. Now we're going to talk about iridodialysis repair, and these are the types of sutures which we're going to discuss right now. The Hoffman pocket, we all know about it. And for the hand-back technique, we're going to have like mattress sutures. But I want to talk about the retroflexion and antiflexion, because these are terms which were described in undergraduate books and they are never mentioned in review of literature. No one is talking about retroflexion and antiflexion. Once there is dialysis more than 3 hours of the ciliary border, this means that the undersurface of the ciliary of the iris will turn upward to the back of the cornea or will turn backward so that the anterior surface of the iris is looking to the optic nerve. If the anterior surface of the iris is looking to the optic nerve, this is retroflexion. If the posterior surface of the iris is looking to the cornea, this is antiflexion. If you don't correct that, you will be in a big trouble. So this is a schematic showing that any dialysis more than 3 hours, there will be turning of the iris backward or forward. Look at this surgeon. He's thinking that this is the ciliary border of the iris. And now, because he's doing that, he's taking the sutures in the middle part of the iris, there will be pupillary migration. Now the surgeon is going to correct the pupillary migration by a suture. Once he does that, the disaster is coming in few seconds. And you will hear now the sirens of the ambulance trying to save the cardiac arrest of the surgeon. Why? Because the surgeon will induce iridodialysis in another way. Why? The surgeon did not think about the retroflexion. Where is the retroflexion? The undersurface of the iris is turned like a cannelloni style inside. Then you have to correct all the cannelloni part of the iris. Take all this iris tissue. The iris is there. It was a closed globe, but it's closed. It's rounded over itself. You have to correct that in order to get the tissue. For the anterior chamber maintainer is extremely important because you can pressurize the anterior chamber and you can change the location of the anterior chamber maintainer according to the place where you want to avoid the battlefield. So you can change your anterior chamber maintainer. Unlike what was told by Professor Dr. Ahmed Masri, in such a case, don't put an infusion cannula, pars plana infusion cannula, because you cannot change the location of the infusion cannula. Meanwhile, you can change the anterior chamber maintained. So retroflexion correction is the main key to restore the anatomical shape of the iris and the pupil in cases of iridodialysis more than 3 or 4 clock hours. For the sewing machine technique, it's kind of like you are going to feed the Prolene suture inside the needle, the insulin needle, and then you go through the iris tissue, then through the sclera, and exteriorize a loop. Then withdraw your needle, still the thread is inside it, then go to the adjacent hour, exteriorize another loop, then inside, outside, exteriorize a loop. What will happen is that we have many loops beside each other, like shown here, and now I'm going to cut these loops so I have 2 or 3 or 4 ends adjacent to each other. Sometimes we have combined iridodialysis repair plus pupillary cerclage. Always remember that now we have to correct first the retroflexion or antiflexion, and once we do that, we'll start to do the pupillary cerclage. Now we are having 2 opposing forces. One of them is pulling the ciliary border of the iris to the sclera, and the other one is constricting the pupil and pulling the ciliary border of the iris towards the pupil. So you need to have some sort of wisdom while you're constricting your pupil. Understand the surgical principles in the exact order. First, correct the retroflexion or antiflexion. Second, attach the ciliary border of the iris, correction of the iridodialysis. Lastly, deal with the pupil either with the cerclage or better with hour-to-hour approximation as shown before, because it's more forgiving. So, if I'm going to correct the chromatic mydriasis, I have one of 2 maneuvers. Either I'm going to take the cerclage like this, and it's not forgiving, or I'm going to adjacent to approximate 1 hour to 1 hour. So the pupil here is 1 hour to 1 hour, then 1 hour to 1 hour, 1 hour to 1 hour. This means that I'm constricting the pupil, but it's very forgiving. I hope that we didn't remove this. So in such a case, you think that it's impossible to gain the iris tissue. What are you going first to do? You have to correct the antiflexion. What is this? This is antiflexion because the undersurface of the iris is looking backward, forward to the back of the cornea. I'm correcting now the antiflexion, then stretching the surface of the iris, putting my anterior chamber maintainer, teasing all the surface of the iris in order to stretch. What's next? I'm going to correct this part of the ciliary border by attaching it. You can do it with the single fold throw, I mean the sewing machine technique. Now I'm stretching all the periphery of the iris. I saw this patient like 2 months prior to the surgery. When I saw it, the iris was there, which means that the more you wait for the iris surgery, the more the iris is constricted and retracted. So I'm preparing my bed. Then I'm going to attach my ciliary border. Here is the sewing machine technique, and you will see that I'm stretching, taking the proper ciliary border. لو خدت البوردر اللي مش مظبوط هيحصل pupillary migration. Then you go exteriorize the loop, then cut, and then attach the ciliary border. Next, you're going to attach. Now I'm going to show that I'm going to attach an hour to an hour, because this part, if I'm going to take the cerclage and close the pupil, it will disengage from the ciliary border. Now I'm going to take this suture to an adjacent suture. I'm correcting the ciliary dialysis which happened here. So can you see here I'm approximating this part to this part with an interrupted suture, then this part to this part, and then this part to this part. And then I'm going to implant my money lens. This is extremely important in Yaman. You have to test the lens, and the haptic passes through the bore of the insulin tip. Sometimes after you implant the lens, you try to put it, it's blocked. So you have to try it before you go inside. So I'm finishing my Yamani. As Professor Basri said, do not exteriorize one needle and then do the other needle. Leave both needles till you adjust your lens. And then as you see here, I'm approximating 1 hour to 1 hour. Of course, I'm going to close all the parts of the pupil, closing as much as I want because I have the whole iris tissue inside. And then I'm doing here the other maneuver, which is photoshopping of the pupil with the cutter of the projector. Okay? So as you see, this is a very kind of like, you thought it's impossible? No, it's not impossible. It's inside the eye. You have to search for the iris. And please, for such cases, don't bring this case with a day of a bulky list of cases, straightforward cataracts. By the end of the 20 cases, you become exhausted and you don't have patience and you don't have clear mind in order to put this puzzle into action. So it's the same idea. I'm going to attach the ciliary border, I'm going to correct the retroflexion, and then finishing my cerclage. The same concept, I don't want to repeat myself. Can we change the pupil location? Yes, we can use the endodiathermy, which was described by Ahmed. So in such a case, if you use the endodiathermy of the posterior segment, what happens in the uveal tissue is some sort of shrinkage. So I'm closing my iris, and then I'm using the endodiathermy nearby the collarettes of the iris. As you see, the iris tissue is shrinking, as if I'm drawing the iris around the circles or the mires of the multifocal intraocular lens. So I changed the location of the pupil. Can you change the location of the pupil by another maneuver? Yes. Excessive suturing. Now you can see that this part of the iris or the pupil, I'm going to move it from here to there. I elevated this edge of the pupil, and then with the cutter I'm going to cut the upper part of the pupil. So as if I shifted, I migrated the pupil by excessive suturing, and then I'm going to use the cutter as if I'm doing a fashioning of the pupil there. Sometimes I need to move the pupil away from a corneal pathology. But again, in order to move the pupil or the iris, you have to free all the synechiae, whether anterior synechiae or posterior synechiae, then you get a scratchable tissue. And this scratchable tissue is movable, and then you can take its sutures wherever you want. So as you see here, I'm going to take extra sutures for the sake of time. I'm closing the pupil, and then with the endodiathermy, again, I can shrink the pupil, and I can use the cutter as a maneuver of Photoshop of this pupil. Sometimes it's extremely important to use the pinhole in your outpatient clinic, because you don't know if the pinhole is going to be used in such a case. You're going to move the pupil behind the corneal opacity. So if the vision is worsening, there is no need for iris surgery. Or there is no improvement with the pinhole, then don't do the surgery. Sometimes we need the pinhole pupilloplasty. In these cases, give me like 2 minutes. Sorry. So sometimes you have the pinpoint pupil in abnormal corneal pathology, like extensive RK, like a very big amount of astigmatism, like very flat cornea. So once you go into a 1.5 millimeter pupil, then you can improve your vision. What are the complications of the iris? You might have to pull the iris tissue very carefully to understand the different stretchable behavior, proper pulsing of the needle in the iris tissue, avoid neovascular iritis or use endotherapy, sometimes intracameral anti-VEGF. Medical history, check the INR, PTT, PTCs, avoid aspirin intakers, renal dialysis patients, bleeding tendencies, and those with prostate medications. And these are the complications: bleeding, so raise the intraocular pressure and the hemostasis, fibrinous reaction, extension of dialysis, cheese wiring of suture, erosion of the suture, pupil migration, lens touch. 2 more minutes, sorry. So what is the take-home message? I want all of us, when we go back home, one of those fast food chains, restaurants, you're going to take a cup of the milkshake or anything. So the cup is like the dough, and the cover of the cup is like the corn. And then with the keratom, use 4 openings in this cup. And then you have to have your glove, put it over the glove, over the cup. Now you have an iris tissue, it's like an iris diaphragm. And then you can create your pupil, you can create whatever you want. An iridodialysis, iris tear, anything. And then gain the confidence with yourself before going into the operating room. Once you do that, you have to master all the maneuvers while you're sitting in your home. When you do that, you go into the surgery.